All right, good morning and afternoon. Welcome to the 2024 Engagement Lounge webinar series presented by the Association of Neurovascular Clinicians. My name is Julie Schauber, and I will be moderating this session, DIDO, Fast Tracking Stroke Care, Unlocking the Door In, Door Out Times for Optimal Outcomes. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-empowered clinicians that fully support the holistic needs of patients and their families because stroke patients deserve nothing less. For more information about ANVC, please go to www.anvc.org and become a member. We do have a few housekeeping items before we begin. The session will be recorded and made available in the members only section of our ANVC website. However, only viewers who attend this live session in its entirety will receive one continuing education hour. Viewers who attend this live session will receive an evaluation from from Arizona State University. After completing and submitting the evaluation, participating viewers will receive a continuing education certificate, but you must attend the entire live session to receive credit. Please feel free to enter any comments or questions into the chat throughout this presentation, and at the very end, we will review questions with our guest speaker. Now, I am proud to introduce our guest speaker for this webinar, Jenny Patterson. Jenny is an acute care nurse practitioner and the director of neuroscience operations at CHI Memorial Neuroscience Institute. She's also a disease-specific reviewer for a joint commission, and she has over 10 years of experience in neurology with a focus on acute stroke diagnosis and treatment. She also completed her PhD in nursing science at the University of Tennessee Health Science Center. And we are so excited to have her here and presenting this very important topic. Take it away, Jenny.
Thank you so much. Good afternoon and welcome to today's webinar on improving door in, door out times for stroke patients. As Julie said, I'm Jen Patterson, and I'm excited to be with you today as we dive into one of the most crucial areas of stroke care. As we all know, door in, door out time is a crucial metric in stroke treatment that directly impacts patient outcomes. Reducing the time between patient arrival and treatment not only improves the chances of a successful recovery, but also enhances the efficiency and effectiveness of the entire stroke care system. Achieving optimal door in, door out times requires careful coordination, collaboration, and a commitment to streamlining workflows across multiple facilities. Today, we'll explore the key factors that contribute to delays in door out times, identifying best practices for improving efficiency, and discuss strategies for enhancing collaboration between hospitals, EMS teams, and comprehensive stroke centers. Our goal is to share actionable insights and practical solutions that can help us overcome these challenges and ultimately provide the best possible care for our stroke patients. I have no relevant financial relationships to disclose for this webinar. Door in, door out, or DIDO, is not a new concept, but it remains a focal point of performance improvement projects at many centers across the United States. DIDO is a crucial metric that evaluates the efficiency of patient transfers. It typically applies to patients being transferred from non-certified centers, acute stroke-ready hospitals, or primary stroke centers to facilities capable of providing advanced treatments such as mechanical thrombectomy, aneurysm coiling, or hemicraniectomies. Faster transfer times are strongly correlated with expedited treatment and improved patient outcomes. The American Heart Association, American Stroke Association Phase 3 target aims to achieve a DIDO time of less than 90 minutes for at least 50% of transferred patients. However, only fewer than 10% of reporting PSCs currently meet this benchmark, highlighting the need for significant improvement across the system. I would like to also point out that the DIDO reporting and get with the guidelines is not mandatory. In 2013, the Brain Attack Coalition recommended a door in, door out time of 120 minutes or less for acute stroke-ready hospitals. One group of researchers reviewed the documented door-in-door-out times from a large sample of hospitals participating with the Get With the Guidelines Stroke Registry, and their results were published in JAMA in 2023. Interestingly, we found that patients presenting with acute ischemic stroke who were eligible for endovascular therapy had a median door-in-door-out time of 174 minutes. Patients with hemorrhagic stroke had a median door-in-door-out time of 178 minutes. And a separate category of acute ischemic stroke, I'm assuming those that maybe were not deemed eligible for endovascular therapy or did not have a large vessel occlusion identified, had a median door-in-door-out time of 201 minutes. A DIDO time of 120 minutes or less was achieved in only 27.3% of cases. It was also noted that a limitation of this study was missing or incomplete data of the Get With the Guideline dataset. This article explored the relationship between DIDO time and outcomes in patients undergoing endovascular therapy. The findings revealed that the average door-in-door-out time was 122 minutes for patients with favorable outcomes compared to 139 minutes for those with poor outcomes. The study highlights the importance of optimizing door-in-door-out times to improve outcomes, but cautions against establishing benchmarks without first identifying factors that improve clinical outcomes. Many of us have experienced cases that have left an impression in our practice. Let me start by presenting a case that underscored the consequence of delayed transfer. This case occurred in early 2018. Remember that during this time, mechanical thrombectomy was still a newer treatment and had just been FDA approved for up to 24 hours from the last known well time. This patient was a 65-year-old African-American woman who arrived at a primary stroke center with severe stroke symptoms reflected in her NIH of 24, indicating profound disability. Unfortunately, the facility lacked the necessary resources to treat her condition. Upon arrival, the emergency department promptly ordered a non-contrast CT of the brain that was completed within 7 minutes of her arrival, and that is seen on the top image. And a subsequent angiogram was performed 3 hours later, and that's on the bottom image. This image shows the confirmed left MCA occlusion. And despite the CSC being just minutes away and equipped to perform a mechanical thrombectomy, the transfer process faced significant delays. This case highlights the critical need for streamlined communication and systems to minimize time to definitive care in cases of severe stroke. One might assume that her transfer would be handled emergently and completed quickly. However, in this case, the transfer took a devastating 7 hours. The scan on the left represents the imaging performed immediately upon her arrival at the Comprehensive Stroke Center. Unfortunately, by this time, the extent of brain damage was too severe, rendering her ineligible for treatment. This case tragically illustrates the critical importance of rapid transfers in cases of severe stroke to prevent irreversible brain damage. The MRI of her brain, shown here, highlights extensive damage from the insult, which ultimately proved fatal. Cases like this shaped my initial bias that patients should exclusively be referred to the Comprehensive Stroke Center to prevent such devastating outcomes. However, I soon recognized my perspective was rooted in limited knowledge and was motivated to deeply explore stroke systems of care. This exploration became the foundation of my dissertation, and I'm excited to share some of my key findings of my research with you today. My first paper was a narrative review of the literature published between January of 1996 and April of 2020. These dates were chosen to capture critical advancements in stroke care, particularly regarding intravenous medications, reperfusion therapy, and strategies to optimize systems of care. The review identified several factors associated with improved stroke outcomes. First was resource availability. The presence of vascular neurologists and dedicated stroke units significantly enhanced patient outcomes. Stroke center certification and compliance with standardized performance metrics have been shown to reduce post-stroke complications and improve overall care. Training ambulance personnel in stroke recognition and management is essential for early intervention. However, pre-hospital stroke scales like the Cincinnati Pre-Hospital Stroke Scale lack sufficient sensitivity and specificity for accurately diagnosing stroke. Scales designed for large vessel occlusion detection, such as RACE or VAN, may better determine the appropriate level of stroke care but are inconsistently used. Barriers include turnover of hospital provider staff and the complexity of the scales. Internal process improvement projects within emergency department for efficient workflows, such as reducing the door to CT time or door to IV thrombolytic times, have enhanced patient outcomes in ischemic stroke treatment. Certifying bodies now advocate for reducing door to IV thrombolytic administration goals from less than 60 minutes to under 30 minutes. Since 2019, the focus on door in, door out times has intensified with proposed benchmarks of 40 minutes or less. However, the reasons for prolonged door in, door out times remains unclear. Despite the emphasis on reducing delays, there's a significant gap in knowledge regarding the contributors to transfer inefficiencies. The findings of that narrative review were used to inform the development of a qualitative study, which examined delays in transfers from primary to comprehensive stroke centers. Here we explored the lived experiences of those involved in transferring patients from a primary stroke center to a higher level of care. The results of this study were published in the Stroke, Vascular, and Interventional Neurology Journal in March of 2023. We identified perceived barriers from within the primary stroke center acute stroke ready hospital, also known as the transferring facility, barriers within the transport system, and barriers from the CSC or receiving facility. I would like to briefly review some of the factors that pose delays to timely transfer and offer you a few things to consider. As we move through each barrier or opportunity, I would like for you to consider not only your organization, but also the facility that you either transfer to or receive from. One significant challenge includes stroke-resistant attitudes among staff. For instance, some colleagues still encounter providers who are reluctant to adopt pre-notification or nurse-driven protocols. Additionally, certain physicians may hesitate to order advanced imaging up front, preferring to begin solely with a non-contrast head CT. While telemedicine can be an effective tool to address these issues, resistance to its activation persists in some programs. In fact, there are reports of telemedicine companies introducing unnecessary delays which can hinder timely care. If your telemedicine provider does not support imaging review, it may be worth considering alternative options. The use of artificial intelligence or AI to streamline imaging interpretation or assist in triaging stroke alerts can also be a valuable addition, offering enhanced diagnostic support and reducing decision-making delays. Although transportation factors encompass a wide array of challenges, one critical point is the need for clarity and communication with pre-hospital providers. Your organization should clearly define the specific information required from pre-hospital teams and ensure these expectations are reinforced through regular meetings and collaboration. Programs across the United States continue to focus on refining treatment times, and many of these tasks are likely familiar to you. Regulatory agencies, along with the AHA, ASA, have emphasized internal performance metrics such as EMS pre-notification, door to CT time, and door to needle time. I'm certain that your team has worked tirelessly to refine these metrics to achieve faster treatment times. However, I still believe that there is an opportunity to go further. For organizations that do not admit patients with intracranial hemorrhages or those who have received IV thrombolytics and know that they will transfer those patients, it is known at the time of CT completion or at the time of thrombolytic administration that the patient will require transfer. If you're consistently meeting your door to CT goals of less than 20 minutes, but your hemorrhagic stroke transfer times exceed 178 minutes, this raises the question, where is the barrier to timely transfer? Similarly, if you identify a large vessel occlusion within 30 minutes of patient arrival, then what is happening during the remaining time that the patient is at your facility? Identifying and addressing these obstacles is critical for optimizing patient outcomes. At the time of pre-notification or patient arrival, do you already know the patient's last known well? If they remain within the IV thrombolytic treatment window, is their blood pressure at or below the target of less than 185 millimeters of mercury for medication administration? Blood pressure management should ideally begin before the CT scan to avoid delays. Does your organization have a wake-up protocol in place? If so, are you notifying the MRI tech during the CT scan based on the patient's clinical exam? Efficient coordination here can streamline decision-making for advanced imaging. We're familiar with the event up to the dotted line. However, what happens after that? Once the IV thrombolytics are administered or a CT scan reveals a hemorrhage, it's clear that the patient will require transfer. This raises several questions. How familiar are your staff with the transfer process? Who is responsible for contacting the Comprehensive Stroke Center? Who arranges air or ground transport? It's essential to critically evaluate your workflows, as delays in initiating the transfer process inevitably prolong the time to definitive care. Conducting stroke transfer drills, like a mock stroke transfer drills, can be a valuable tool to assess these workflows, assign clear roles, and ultimately reduce your door-in, door-out times. This will allow your teams to be intimately familiar with the transfer process and will help to identify breakdowns in communication and workflow. In this article, researchers concluded that the CTA to ambulance notification time is the longest contributing interval, making up almost 40% of the door-in, door-out time. Transport factors are often independent of the transferring or receiving hospital and can be influenced by geographical location, weather conditions, and ambulance availability. In some states or systems, routing guidelines may impact performance and introduce potential liabilities. Additionally, challenges can arise based on whether the transport is handled by a county-operated ambulance service or private agencies. Given these complexities, it may be beneficial for your organization to collaborate with EMS partners to develop protocols or use transfer readiness checklists. Early activation, even with the understanding that crews might be called off if unnecessary, could place your team ahead in the transfer process. Staging EMS crews Some EMS crews remain on site with patients who are within the treatment window or have specific clinical indicators, and this expedites transport decisions. Finally, providing regular feedback to EMS teams can strengthen partnerships, foster collaboration, and support continuous quality improvement efforts. Building strong relationships with EMS agencies is essential for optimizing transfer process and patient outcomes. In your region, do acute stroke-ready hospitals or primary stroke centers routinely get bypassed? Upon arrival, does the EMS crew stay on site, or are they dispatched only if specific exam criteria are met? Does EMS use an LVO detection scale? These practices often depend on local systems and protocols. Additionally, does your facility primarily transfer to a single comprehensive stroke center, or are there multiple options? In some systems, I've heard of scenarios where one facility contacts up to 3 CSEs waiting to see who will accept the patient first. This can create additional challenges, and EMS personnel may remain in limbo until the decision is confirmed. During this waiting period, it is crucial to use the time effectively to prepare the patient both for discharge from your facility and for treatment at the receiving center. Collaborate with your CSE to develop a standardized transfer readiness checklist to streamline this process. Items to include may involve EKG lead placement to ensure cardiac monitoring will not be in the way of the cath lab images while the patient is in the endovascular lab. IV access requirements such as securing 2 large bore IVs if possible. Dressing the patient in a gown with their pants removed for imaging and examination readiness. Preparing necessary documentation for transfer, including imaging and lab results, and then ensuring the patient is discharged in your system so that the receiving facility can create an encounter in theirs. This is especially critical if you are within the same system and use the same EMR as your sister hospital. Proactively planning clear protocols and strong communication with EMS and CSC partners can improve transfer efficiency and patient outcomes. Regularly reviewing workflows and providing feedback to all stakeholders is essential for continuous quality improvement. Transfers can often be delayed due to complex communication pathways. While transfer centers may help facilitate these processes, PSC teams may still need to make multiple phone calls or speak to various members of the CSC treatment team before a transfer decision is reached. To streamline this, establishing a dedicated point of contact at the CSC may be highly effective. If the CSC also serves as a telemedicine provider for your facility, this can further reduce the number of calls and simplify communication pathways. Additionally, integrating artificial intelligence into workflows may expedite diagnosis and clinical decision-making, ensuring faster transfer coordination. Bed availability and staffing shortages may delay transfers or result in sites declining patients. Differences in EMRs can slow down the exchange of critical patient information. To mitigate these issues, consider the use of handoff checklists to ensure the receiving team has all the necessary information. Collaborating with the CSC to develop clear, standardized protocols and leveraging technology like AI and telemedicine can significantly reduce delays and improve patient outcomes. While we diligently track stroke metrics at the Comprehensive Stroke Center, from patient arrival to puncture time and even revascularization, there are often gaps in evaluating the transfer process itself. Are we paying enough attention to key moments leading up to the patient arrival? Key questions to consider. When does the PSC initiate the transfer call? Are we tracking the time from the PSC decision to the contact of the CSC? Who reviews the imaging or accepts the patient at the CSC? Are there delays in this step, and can we streamline it? Does EMS require a bed assignment to dispatch to the transferring facility? If so, how can this process be expedited? Upon CSC arrival, who receives the patient? Is there a clear protocol, and is the process efficient? One potential solution is the implementation of a stroke transfer coordinator. This role focuses on managing communication between the PSC, CSC, and EMS, ensuring timely review of imaging and transfer acceptance, coordinating patient arrival and handoff at the CSC, and having a dedicated person in this capacity can significantly reduce delays and create a seamless transfer workflow, ultimately improving outcomes for stroke patients. Current door-in, door-out times at many facilities exceeds recommended guidelines, highlighting the need for system-wide improvements. And addressing these delays should be a collaborative effort, one that involves every center within the system, not just the transferring or receiving facility. By working together to streamline workflows, sharing best practices, and identifying barriers, we can create a more efficient and patient-centered process, because stroke patients deserve nothing less. Thank you all for your time and engagement today. I hope you found the discussion improving door-in, door-out times valuable, and that you're walking away with actionable ideas to enhance stroke care in your own systems. As we continue to improve care, identifying and overcome barriers to timely transfer is a crucial next step. If you're interested in participating in a research project aimed at identifying and addressing these barriers, please don't hesitate to reach out. If your insights and experiences could play a significant role in shaping the future of stroke, and I thank you and wish you all the best in your continued efforts to improve stroke outcomes.
Thank you so much for that, Jenny. I think that was such an enlightening talk on such an incredibly important topic, obviously. We have a couple questions. One was, will the slides be available after the webinar? We are not emailing the slides out, but the recorded presentation will be available in the members only section on the ANVC website. So that will be available. We also had someone here, a question saying, our site has worked to reduce the time between CT and CTA for thrombolytic LVO patients. Do you have any thoughts on what an acceptable turnaround time frame would be as we are looking to create an internal benchmark?
Sure. So I am a huge supporter of administering IV thrombolytics in CT. So in our facility, we get the non-contrast head CT first, administer IV thrombolytics while they're on the CT table, and then immediately start the CTA. I think that this is where it's really important. The use of AI in this space is huge. Most of our neurologists and telemedicine neurologists are reviewing our own imaging, and then having a process in place where your radiology partners are notified immediately. I've seen some facilities, that I think most of the time the CT tech is calling the radiologist, and then there's a direct communication back to the neurologist or the emergency department physician for timely reads. I think that takes a lot of coordination and a lot of work. If your telemedicine providers are not looking at their own imaging, and of course, oftentimes when we have telemedicine providers, we also are utilizing, Nighthawk or VRAD or some type of offsite radiology partner. I think, having a direct communication to them so that there's not like, who do I call and how do I call it, is crucial in those moments. And in some of the applications for image sharing, so like AI technologies, there's actually a text function where that does not replace the report that has to be placed in Epic or documentation of the call to the provider. But I think we have opportunities to really drive down our goals for CT read and for CTAs. In some of my research, which I have not published all of these results yet, even for the cases where I had prolonged door in door out times, the mean CT time was around 11 to, I think it was 11 to 15 minutes for CT completion and CT read. And then CTA was a little bit more prolonged, obviously. And off the top of my head, I think that it was around 34 minutes, which I think that we have opportunities to drive that down. I would like for agencies to come up with a benchmark of what they would deem acceptable in those times. But I think it's really important that we get away from ordering a CT, going back to the department, having physicians or nurse practitioners, PAs evaluate patients, and then send them back for CTA. Stroke is a vascular disease. And in my opinion, I think we have to, be clear on our protocols of when we're activating stroke, when we are pushing towards doing all the images, all the scans. But if you're ordering a CT, majority of the time you should be getting a CTA immediately after. So I don't think that completely answers the question with an actual time frame, but in my opinion, it should be less than 30 minutes, less than 20 minutes.
All right. And I'm going to move to the next question. With limited resources, how can facilities find success with gathering these details case by case? Workload for the coordinator is often challenging with all the to-dos and or want to-dos.
Yeah, excellent question. Excellent question. As a stroke coordinator or data abstractor in your facility, you're probably one person, and most of the time you're also the STEMI coordinator or something like that. So I think that partnering with in your core stroke team, um, partnering with your providers. Most of us are using some form of electronic medical record, which allows um, the use of templates, which I think would be really helpful. Employ your providers to collect some of this information for you. If in our own facility, we use something a little bit different, but the end product is a note that at the top has most of the key metrics that we're looking for. So the providers are entering kind of timestamps to when certain things are being completed. This will save you from having to really search the chart and try to figure out, was this, at 9:30, was it at 9:32, things like that. So I would first start with your providers to see if they could form a template that would help you. And then I think that, depending on the volume of your center, oftentimes we aren't really um, staffed appropriately for the resources that we need. So documenting the things that you're doing as a stroke coordinator, as a data abstractor, utilizing your quality team to make a case for um, acquiring more resources.
And sorry, the next question is your neurologist in CT or telemedicine? We do not have telemedicine consult while in CT.
Okay. So in my personal facility, I have both. During the day, I have a neurologist on site, and at night, I have telemedicine. In our smaller hospitals, we have telemedicine 24/7. Our telemedicine carts sit in CT. So you're not utilizing resources with nurses having to wheel carts back and forth. Um, the patient is evaluated in CT just as if it was the physician walking in. So EMS is taking the patient directly to CT, and they are talking to the telemedicine provider is activated at the same time that the stroke alert is activated. So they are typically on screen waiting in CT when EMS arrives. And then they review the images. Oftentimes, it may be that they need to examine the patient again or have additional conversations. So sometimes that does require taking the cart into the emergency department area. But for the most part, they are seeing the patient in CT.
I think that's a great idea. Are there any other questions for Jenny? I just had a comment. The topic of does EMS need assigned to the comprehensive stroke center before they'll be able to transfer the patient. I think as a comprehensive stroke center, we need to find ways to make sure there is always a bed available, right? And I know that in this, with issues with length of stay and insurance approval and whatever it may be, that's not always the most feasible thing. I can tell you, just an example of perhaps a solution is we just worked with our emergency department team, and if we don't have an ICU bed, we call down to our ER team and we say we need if the patient just comes straight to ER, which, might not be an option in all cases, but it's allowed us to basically not turn away any patient and to not delay it for that exact reason, because we used to run into that every once in a while too.
Yeah, I completely agree. I've worked at two different facilities and we did it different in both facilities. So in one facility, every patient came through the emergency department. So it was an ED to ED transfer, ensuring that there was always a bed. And, now you're seeing more and more times and with imaging, being what it is, and the option of image sharing. Patients are going directly from outside facilities to the lab directly. But in the facility that I work with now, they are kind of adamantly against ED to ED transfers. So some of the solutions that and we haven't really had to use this much, but we've also we have in our protocol that we would utilize like PACU for those patients. And so we train those nurses as well, and they're involved in our Stroke Champions Committee, but they're typically in-house, extended hours, or at least have someone on call. And so if we're getting a transfer from an outside facility, we know that that's going to take at least 30 minutes or greater, right? So we kind of have a heads up that they're coming, so you can call the staff in, and then they can monitor that patient until an ICU bed could be made available.
Yeah. We have another question, which I also have, which is, how can we assist with your research?
Excellent. So my phone number and email are on the screen. And my last study that I'm working on right now, I'm looking at delays in transfers from primary stroke centers. So keenly interested in having primary acute stroke ready, non-certified centers that are transferring patients to basically complete an instrument that I developed during my dissertation. And I'm presenting the validity of that instrument at ISC through a poster session. So excited to start to share some of those things. But if you have primary stroke centers, or if you are a primary acute stroke ready hospital and you would be willing to participate with me, it is an IRB approved project. So I will just email me. I will send you the form. You fill it out. One patient is one form. You can fill out as many as you want and can be included. So I would love that.
Yeah, I think that's great. So it's one form that the PSC coordinator or acute stroke ready or non-certified, they fill out per patient. So it's not an intensive, labor intensive project. Okay.
It's mostly information that you're probably already collecting. And then you fill out a couple just Likert scale questions based on the experience of that particular patient. And then send it back to me. It is de-identified, so I don't collect any patient information or HIPAA information on it. It's strictly just times, results, and your opinion.
Right. Are there any other questions for Jenny? Okay, well, we will give everyone 20 minutes back in your day, but reach out to Jenny with any further questions. And again, you can watch the recorded session on the ANVC website under the members only section. Thank you.
Thank you, guys.